Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and we're going to have to get, I've offered to give like Saturday Night Live jackets to repeat doctors that come in. So Dr. Kyle Lemley is joining us, Pediatric Critical Care Specialist and pediatrician. This is only 4, though, so you got to get to 5.
I was hoping just like gold stars, because I am a pediatrician, so stickers.
Oh, of course.
They work just fine.
Of course. That's what stickers, obviously.
Yeah, obviously.
Well, it's glad to have you back, Doctor. I appreciate it.
Great to be back.
You coming in. And joining you today are your nurse educators. Is that what, that's what you're known as? That's your official title?
Yes.
It's Amy Morrill, who is a nurse educator, and Amanda Horsley, also a nurse educator.
Nurse manager.
Nurse manager. I'm sorry. There's 2 different things. The nurse manager. Now, what's the difference between the 2? First off, what's a nurse educator?
Great question. My role is multifaceted as far as I do a lot of education with our nurses. I also work bedside, so I take care of patients on the floor as a charge nurse. And then I also dabble a little bit in some leadership things as far as supporting our team and going from there.
Oh, wow. So it's like a step above then, would you say? I'm just like you probably consider yourself a step above no matter what, I would assume.
I mean, always, naturally.
So then Amanda, what's a nurse manager?
Like Amy, I also do a lot of supporting with our team, supporting our physicians and growing our services, and then a lot of the operational work of our unit. And
Dr. Lemley, this is your team in essence, correct?
Yes, this is my team. We, as you know, and I think the community knows, we're interested in growing the pediatric services that we provide in the community, inpatient and outpatient as well. And so not only do these ladies help inpatient, but then when I need something that is like, okay, this is for growing the outpatient world, then they step up and help. So they go above and beyond what their actual role is and work tirelessly to help the kids in the area.
That's so good to hear. And it's so exciting what Monument is doing in growing this part of the hospital, isn't it? I mean, you guys have to feel excited and ready to go with this.
Super excited and ready to go. Amy is representing our logo and
the logo is fantastic. Yes. When did that get done?
I would say this summer.
Okay.
Probably
we finally could
summer.
announce it this summer.
Yes.
Yeah.
I wonder if you paid attention to the CMN fundraising things from the summer. The logo was actually on some of those banners and everything. So it was at Sam's and Walmart, I think. It was,
right.
And then it was on the banners hanging up in here for the...
Yes, it was.
For the
I had no idea that's what it was for, though.
I know.
You guys were sneaky. Nice job.
We're ninjas. Ninjas.
That's how we
and we're sedation ninjas, too. We'll talk about.
Hold on a minute. That's kind of what we want to talk about in this first episode with you guys here, all 3 of you in the studio with me. Is pediatric sedation. And, I guess as parents, do you guys all have kids?
Yes.
Yes.
Okay. I suppose as a parent, as a doctor, your kids grow up kind of knowing what all of this stuff is, don't they?
Yes.
Do they understand what you do? They understand the terms. But to the rest of us, if I had to take my kid in and I heard the word sedation,
it's terrifying.
It 100% is. So can you walk us through kind of, what it is and why it's so vital for what you do?
Yeah, well, I think one reason it's terrifying is sometimes we use the wrong words. I'm like, we're going to put your kid to sleep for the MRI. And then it's like, wait, you put dogs to sleep. You shouldn't do that.
I've never even thought of that. Yeah, exactly.
Trying to use non-scary words and just saying what they are of sedation and everything else. But a sedation service is designed to help kids get through procedures. Kids need MRIs and CT scans and different painful procedures that they can't just hold still for, unlike you can convince an adult to go get an MRI scanner and hold still for 30 minutes. And if they're not doing it, you can shame them and everything else and just get it done, right?
Yeah.
You can't do that with a kid. And so trying to get a 3-year-old to go into a little hole in an MRI scanner that's super loud and scary, and even though we tell them it looks like a spaceship, that doesn't matter. They're still just not going to sit still through it.
Yeah.
So this is the way that we can kind of get the studies done and get them done safely and effectively, and be able to help the outpatient providers, inpatient providers get the studies done that they need.
And my first thought with this was, obviously, when I heard the word sedation, I'm thinking, oh, well, how is it any different from just putting an adult asleep to have a procedure done, not even thinking about the CAT scans and the MRIs and everything you just mentioned, that to a child, like you said, is absolutely terrifying, right?
And when anesthesia was doing it for us in town, which they did it for years, we just recently, they let us take the service over recently this past fall. And we are way different from the tune that we don't put a breathing tube in at all. We use medicines and keep the kids breathing and safe without putting in any kind of tube and putting them on any kind of machine or anything else. And so it just is a safer way to get the procedures done.
Right. So then how do you guys factor into this too when that's happening? What is your role in this when you guys are ready to have a child be sedated?
Well, an exciting thing that I get to do is actually take care of the patient. And so we get to have the patients come up. We get to talk them through the sleepy time part and bring their stuffed animals and bring everything that's comforting to you, as well as give some comfort to the parent that this isn't as traumatic as what maybe it has been in the past. And so let's take all of your considerations in and make this as easy as possible and really give them comfort and peace knowing that your kiddo is going to be just fine and sleep a little bit, and we're going to get these procedures done that in the past could have been really scary.
Yeah. You guys just remind me of like first grade teachers. You're just, I mean, the way that you have to approach these kids in order to make them feel safe and comfortable, because all of that has got to be scary no matter what. So how do you ensure kids, kids and their families, I guess, to feel at ease before a procedure like this, especially when they're anxious or scared? What do you do?
We often start with a pre-phone call with the parents. So we like to talk the parents through what the visit is going to look like, everything from check-in to getting up to our floor, what our nurses are going to do with the kids, what the procedure will look like, and how the family can support the child through it. So we want to make sure we have a good understanding of the family and that they are ready for the procedure and ready to support their kid through it and to help us with that. And then, of course, when the kids get to the floor, kids are all of our passion. And so we just talk to them like we would any other patients and let them know what they're going to do and what it's going to look like. And as long as you keep them informed, they tend to be on board.
It seems like, kids don't necessarily come in scared to these things. I mean, in the sense that as an adult, if I know something's wrong, I am going to be a little worried about it. I am going to have a little trepidation about coming in to do this. But it does seem like, do you find it easy with most kids to get them through this, or is it more of a struggle?
It depends on the child. If
Okay.
this is their first encounter or something like that, they don't have that background of something being scary to them. However, we do see a lot of chronic kids that they have been through this a lot and have had multiple pokes in the past, or things were loud and scary. And so it is terrifying for them because they have that traumatic past of anything that's happened.
And then you have stranger danger, right? So then
course.
Kid gets into an unfamiliar place and they're scared, and then the parents are nervous. So then the kids are scared because the parents are nervous. And so it's really just, it's a big cycle that we really have to just kind of work on figuring out where we can go in and break that cycle and make it so that the family is comfortable and the kids are comfortable. And honestly, educating the parents on how to talk to their kids and educate their kids on what's going to happen helps out as well.
Is there parental sedation at some point? Would you like there to be at some point?
I'm sorry, this is not off the record.
We only do kids.
We can talk later.
Well, we will. Is there a myth about sedation that you hear from parents that you worry about? Are there some things that you? What are some common ones you guys hear? Because I'm sure you hear it all, don't you, when they come in to do these kind of things?
Yes, I think always a big fear factor is your kids are crying and they have to get poked for an IV placement, or they have to do things that hurt them, and then it triggers that traumatic response as far as crying and tears and emotions. And I think that's the biggest factor that we deal with. So when they come in and we explain, the plan is to give you a little bit of some weird medicine up your nose to help you sleep, and you won't feel anything right now. And I think that gives a lot of ease, but we got to get them on our side to truly believe us too that that's where we're headed.
Man, there is so much psychologically that you guys got to do before any of this even starts.
Yes.
Is that training a part of what makes you an educator and a manager? Is that all part of that too?
I would say absolutely. We know that every traumatic experience that a child has, it takes at least 3 positive experiences to kind of negate that poor experience that they have. So we do a lot of training with our team about how to make this experience as positive as possible for both the patient and the family. We know that it can be really traumatic for a parent to see your child go through that hard time too. So we want to make the experience as good as we can for both of them.
Now, is most of the sedation, is it mostly like the gas related, or is a lot of it involved with the IVs and that type of sedation for this?
It's actually evolved even more than that.
Really?
So talking about like how do we customize sedation
right.
and make it custom to each kid and for age and everything. So for infants that are really 4 months or less that need an MRI, we don't even sedate those kids unless they fail getting the MRI done or CT scan done, which is feeding and swaddling them. Mm-hmm. So we really good at that. We try to get those infants to still come through our service, even though we're not going to sedate them. It's just because we're good at feeding and swaddling and helping, comfort those little babies through. And then when we do the pre-sedation phone call, we talk to the families and kind of get a sense for how the kids are. Are there behavioral issues that we need to know about, big fears or that kind of stuff? And so then every Thursday afternoon, we actually talk about all of the kids we're going to sedate the next week and kind of come up with a plan for what that's going to look like. Amanda and I went to a sedation conference in September in Boston, and people were starting to talk about a poke plan. So does a kid need an IV? If they do need an IV, how are we going to get the IV in without the kid really knowing about it and without feeling it? And how are we going to make this as non-traumatic as possible? And so that's one thing that we really focus on is what are we going to do? How are we going to address the sedation to minimize the pokes and minimize the trauma? And so most of the kids actually don't even need an IV to get the sedation that we give. And then we talk to the family about if they would be comfortable with just a nose spray or an oral medication, or some families have told us that their kids don't respond well to nose sprays and wouldn't take oral medicine really well, but getting a shot would be something that their kid would do better with than others. So we have several ways that we can help and get kids initially sedated. And then kind of depending on how long the scan is and what all else is going on, they may need an IV, they may not need an IV. But we've gotten to where we give a medicine called intranasal Precedex or dexmedetomidine. So just a nose spray of this medicine, and we can the kids most of them go to sleep within 20 to 30 minutes. It mimics regular sleep, and so they're actually just asleep like they would be at bedtime. We put a little anti-pain cream on their arm, and then if they need an IV, we can put the IV in without them even waking up and knowing that we're doing it. So
that is like a superpower to have for sure. I'm just trying to think of the kid. God, he would have been the coolest kid in school. No, just give me the shot, doctor. All right, I don't need anything else. I'm just trying to picture what kid would that would actually work on. But wow. So are there? Obviously, you kind of mentioned when you started this that there must have been breakthroughs in sedation techniques that are just going to keep getting better and better and better. I mean, when you started doing this, do you remember? Was it just needles? Is that the only way they could really do sedation? I mean, outside of when you go to a dentist or whatever, and they can put that on your face. But
yeah,
I mean,
you've always had nitrous and anesthesia gases and stuff, but otherwise. When we first started the sedation program, we were planning on holding the kids down, getting an IV in, and then doing some kind of medicine in the IV to sedate them with. But the big advancement is Are we going to do it?
Yeah.
Okay.
Intranasal
Presidex.
All right, now why did you guys have to do it like that?
Because we're cool.
I mean, that's just been the one big thing that we learned about at the conference, that a lot of sedation programs across the country are using. I came here from Wichita, Kansas, and we were doing 80 to 100 sedations a month, and we weren't using intranasal Presidex like other programs are, but other programs are using it to get IVs in, to get scans done, and we've had a lot of success in kids up to 12 using just intranasal Presidex to get a scan done that's about 30, 45 minutes in length, and they sleep right through it.
So that can actually be used, that's like a pre-sedation if you need an IV in some instances, or can just work for some kids?
We originally planned on using it as a pre-sedation to help with that IV to make it less traumatic. And we've really found that it's been successful to keep our kids asleep through the whole procedure, and they haven't needed an IV, which is huge. One less poke for them,
Wow.
one less thing for their parents to worry about.
Yeah.
So
Well, it
it's
is
been great.
amazing anymore. Even if you go to give blood, it seems like the needles and the things they use are almost to a point where you don't even feel these anymore. I don't know how you guys have done that, what kind of wizardry that is.
We're doing
but
good.
It is. You guys are fantastic.
Magicians don't share their secrets. So.
That's right.
We talked a lot about parents and guardians and the roles they play, but what is important for them to do during this process, and how do you keep them engaged and informed as you're going through this whole thing?
We like to prep our parents ahead of time so that they know what to expect. One thing that we ask is that they bring along things that are comfortable for their kids. So whether that's a blanket or a stuffed animal, a special pair of jammies, a favorite story. As Kyle had mentioned earlier, this medication really works to create natural sleep. So we want to create an environment that's as similar to their home sleep environment as possible. So we ask those families, rock your kid, read them a story, act like you would at any other normal bedtime. And then that really gives those families back control of the situation, lets them be able to comfort their child feels safe with them, and then they fall asleep. And
Now,
then it's our turn.
Is this something you do later in the day generally with kids, or does it matter? Because the way you make it sound is like, if you're trying to relate that to a bedtime at home, at 10 a.m., that might be a little off, but.
No, it's more often in the morning,
Right.
unfortunately, but I think that medication helps you to feel that sleepiness. And so if we can support them through those regular routines, then it helps those kids to just fall asleep and let the medication work a lot faster.
Okay. How long does it take medication like this generally to wear off in a lot of these kids?
It kind of depends on the kid.
Sure.
So since it mimics regular sleep, also depends on how well your kid has been sleeping.
Yeah.
And so once they go to sleep, if they've been kind of sleep deprived, they're going to sleep longer than not. And the drug probably wears off within an hour or two, or probably an hour to hour and a half total. And then, but some kids, we see them take 3 hours to wake up. Other kids are awake within an hour. So it just
Wow.
kind of depends.
Okay.
It's not our ideal drug from a length of time that you have to stay in the sedation unit, but from a safety standpoint, there's really minimal side effects from it. And it just puts you to sleep like you're going to sleep at bedtime. So from all of those standpoints, we happily take the length of time it takes you to wake up,
Right.
and monitor you for that long to minimize the risks.
Yeah. So what is the shortest procedure you would use sedation for? Is there one?
I mean, for a CT scan, that's like 3 minutes.
Yeah.
Well,
And you could still use it for that. And it's basically just to keep them calm in most instances. Best if they could sleep for half an hour to get through that, I suppose.
Yep.
What's the longest situation or what you would use it for? Outside of surgeries or anything like that?
Yeah. The longest that really outpatient sedation is kind of designed for is up to about 3 hours.
Okay.
Anything longer than that, we would punch you over to anesthesia.
Yeah.
In our current state, I can't think of a kid that we would actually need to have sedated for 3 hours. That's usually more of a hem-onc patient, a cancer patient that's getting multiple scans, multiple levels, and different stuff done. So,
Well, maybe this is a silly question, though, that just popped into my head. What is the difference between the sedation and the anesthesia.
So, yes, we cross over a lot.
Okay.
Anesthesia can do what I can do. I can't do what anesthesia can do.
Got it.
Once you need, if you have a kiddo that has a more complex past medical history, different heart problems, different breathing problems, I might not be able to do them as an outpatient. So anesthesia would step in and do that because a breathing tube would be appropriate and would be more appropriate for them to do it. And then putting them under deep enough where they need a breathing tube and need to be paralyzed for the procedures and all of that kind of stuff.
Okay.
Definitely falls under anesthesia's purview more than mine.
Oh, that makes sense. Perfect.
So.
Well, you guys have dedicated your careers to working with kids. So obviously there has been some stories that have come out in the times you've done this, right? Are there any that really stick out for you? Of course, minding the HIPAA rules and everything. Do you guys have stories where kids have come in just terrified, but by the time it was all done, they love you guys and they want to come back? Does that happen? I mean, does that?
We are pretty lovable.
Yeah, well, I totally can tell.
Yes.
So, did you guys have anything that sticks out in your mind or that are memorable for you in that way?
I have a particular patient that she was very scared. She was a chronic kiddo that was coming in for an outpatient MRI procedure. And she came up off of the elevator, and Mickey Mouse just happens to be her favorite and best friend. So, of course, Mickey Mouse came along. And she got off the elevator, and she held Mickey Mouse right in front of her face while I was meeting her there. And she says, "Me and Mickey Mouse are really scared today." And I said, "Okay, let's talk about this. What are you afraid of?" And she said, "I'm afraid of the pokes." And so obviously this was a kid that had been through this a number of times, and that's what we deal with a lot. So we went back to her room and we talked about it. And I said, "How about I give you a little bit of sleeping medicine and Mickey Mouse can get some too?" And so we wrapped Mickey Mouse up and we got her comfortable. And when it was time for the intranasal Precedex time, we gave a little bit of water to Mickey Mouse and then gave her some of the medicine too. And so then it was fine. And she actually kind of giggled and said, "Oh, that feels weird." And I said, "I told you." And then she and Mickey Mouse fell asleep. Mickey Mouse and her went down for her little procedure and came back. And by the end of it, she was awake and she was inviting me to her birthday party, actually. So it's
Only if
like,
you brought the medicine.
Only, yes, that's right. Yes. But it's those things that I think as peds nurses, sometimes those scares for our kids can be just as traumatic for the nurses too, because we don't want to inflict any harm on them. And so to see that outcome, that they want you to come and they want you to be a part of their world still a little bit, is just as rewarding as seeing those kids do phenomenal through these procedures.
Yeah, that means you nailed it for sure.
Yes.
Well, do you have anything
and Mickey Mouse.
Yeah. Mickey, you'll be fine. Amanda, do you have anything like that?
No, I would continue with what Amy said. We see a lot of kids that come to us very fearful from past experiences, and we are just working very hard to be able to give them some great positive experiences so that coming to CF doesn't have to be as scary.
Yeah, well, that's what I think is just knowing what you guys have been doing and what you're trying to do over there and what's coming. I'm just going to leave it at that, all right? It's exciting. It's exciting that kids don't have to go to Denver. They don't have to go to Minneapolis or Rochester. I mean, that as a parent is almost as comforting as anything, is knowing that, that day I'm not in a hotel with my kid. I'm not staying overnight in the hospital. They're going to be home in their own bed. Mm-hmm. And health outcomes have to be dramatically improved because of that, don't they?
Yes, absolutely.
I think so, yeah.
Yeah. Mm-hmm. I mean, you guys have to absolutely love that. No, go ahead.
We've seen the impact that traveling has made on the families in our community, and we're very passionate about those kids and about providing the services that we can to those families so that they don't have to travel out of our community, because we know that can be a very big burden.
It is. We live so far from everything, really. I mean, but it feels close sometimes too. But, when you have a sick kid, there's just nothing you won't do. But if you can do it here, 100%, let's stay here. Well, Dr. Kyle Lemley, pediatrician with Monument, thank you for coming in again, of course. I love having you in here anytime you want. You're invited to see Amanda again, of course, too. So
Sweet.
Come back and let's do it. Amy Morrill, nurse educator, and Amanda Horsley, the nurse manager. Thank you guys for coming in and doing this. I really appreciate it.
Thank you.
Thank you.
Thanks, Mark.